हूटर बजा रहा हूँ फिर भी कोई सुनता ही नहीं.
I think respected chairpersons and dear sir, Dr. Shantanu, thank you for the opportunity. And it is actually a tough job to cover almost 50% of what we see in our acute emergencies, that is unstable angina or NSTEMI, in 15 minutes. I have to do an outline in 15 minutes. Hope I'm able to touch all the points and able to give you some. I think we all know what has to be done in NSTEMI, but still I think at the end of my lecture you will learn something new. So I think for the beginners, I think NSTEMI is very clear that there can be ECG abnormalities, there can be ECG not normal. But once you have a troponin elevation, then it's called NSTEMI. If the troponin is normal, it's called unstable angina. And then I will go into the details of this. So what is the definition of clinical presentation of NSTEMI? So most commonly, 80% of patients present with prolonged anginal pain at rest, and new onset angina is actually only 20% of patients, and crescendo angina can also be found in some percentage of patients. And 2/3 of patients of unstable angina are NSTEMI with showing a particular enzyme rise. But this is a very common thing. Like somehow we have a habit of telling our patients also she has a mild heart attack. This is a very common term that is used liberally by a layperson as well as the attendants. But it's not a minor heart attack. Let me assure you this. This is what the important number that you have to understand. In hospital mortality, even though it is half of STEMI, by 6 months it catches up. In the long term, it is actually 2 times of STEMI at 4 years. So it's actually a worse disease than STEMI. STEMI hits hard in the start, but it slowly kills. It's a slow poison kind of a thing. It's not such a slow poison, but it kills equally as effectively as STEMI. So how do you risk stratify patients? We have 2 important risk stratifications which are very well proven. One is ECG and another one is troponin. So ECG, what are the important risk stratification tools that we have? So definitely ST depression along with transient ST elevation as the worst prognosis, followed by ST depression alone, or then T-wave inversion, and then normal ECG has better prognosis. So if you have a T-wave ST depression of 0.1 millivolts, 11% rate of death and MI at 1 year is there. If there is a 0.2 millivolt ST depression is there, then there is a 6-fold increase in mortality risk is there. A number of bleeding showing STD changes and magnitude of STD changes also matter. The most important thing that we all have to know is the patient who is showing an ST elevation in a lead AVR is a different ball game, and that patient could be having a left main disease or a triple vessel disease. Any patient presenting with ACS, always look at AVR. AVR is an orphan lead. Most of the time it is overlooked. I think always specifically look for AVR. And if there is an ST elevation, when all the leads are showing ST depression, that patient could be the highest risk patient that you will be encountering in your practice. So coming to the biomarkers, this is how the biomarkers have evolved over time. I think after 90s, it's only troponins. Like for all practical purposes, always troponin. And almost after 2007, it's almost always high sensitivity troponin. So many of you know how you are using troponin. All of you should know which brand of troponin you are using and what is the sensitivity and specificity of the troponin assay that you are using in your hospital, whether it is a quantitative or a qualitative assay, and whether it is actually a high sensitivity troponin. So all of you ask yourself, what is the difference between troponin and a high sensitivity troponin? So let us go into that in detail. So basically the way troponin release has never changed. I think that's a common thing that has happened throughout the ages. But the ability of our assays to pick them up has improved over time. From 1995, we were able to pick up only at this point. From 2003, we improved assays. Now we have very, very high sensitivity assays. We actually have a very precision, at a very low thresholds of where we can detect acute coronary syndromes. So this is just a graphical diagram to make you understand what makes it a high sensitivity troponin. So, for example, this is what is the norm curve. And this is what is the limit of detection. So earlier era, we had a limit of detection of troponins here, whereas we were able to pick up only the troponins which are actually above normal. Above in a particular group only we were able to detect. And this was the 99 percentile that was there. But then once you have a high sensitivity troponin, so the contemporary LOD, the limit of detection actually has moved. So this now is almost, we are able to move to the other extreme. So we are able to measure most of the troponin elevation that happens. So the 99 percentile is here, and the 10% the variability. The variability that, for example, if it says 0.01, how much is it variable and how much it will be 10% variability? That limit has also come down dramatically. So this actually what makes it troponin. So clearly now we are getting into the range where we are able to detect within 2 to 6 hours of troponin, high sensitivity troponin assays, where actually the 99 percentile detect range actually falls here. So this is the definition of high sensitivity troponin. So a total imprecision at 99 percentile value should be 10% of CV, and then it should be 99 percentile should be attainable concentrable value, the assay limited reduction at around 50% of healthy individuals. You do this assay, that measurable concentration below 99 percentile should be attainable in all healthy individuals also. So recommended interval to repeat the test after initial high sensitivity troponin for rule out is suggested to be 3 hours. So I think you have to make sure that what troponin you are using in your setup, and based on which you have to strategize how to discharge or admit the patient and send the patient for angiogram. These are the various algorithms that are suggested currently, either early rule in or rule out algorithms. Like depending on the troponin, if the pain is more than 6 hours, then you find out if there is a troponin less than upper limit of normal, then definitely it is you have to alternative diagnosis has to be done, and then you do a discharge or pre-stress testing, or you can go for a CT angio here. And then if it is pain is less than 6 hours, you are supposed to retest it around 3 hours, and the delta change, if it is more than 20%, you actually diagnose NSTEMI. If it is positive, there is no issue in diagnosis. So what is another algorithm that has been suggested is the rapid ruling, where actually you can rule in very rapidly using this algorithm. So not only it helps in diagnosis, it is very, very important in prognosis also. It actually exponentially, the prognosis of any NSTEMI long term actually worsens with initial HS troponin concentration. So as can be seen, like the mortality dramatically increases with various levels of troponin. So to summarize what I meant about troponin is that always know what test you are doing in your place. It is like it's not one test that we are doing across India. You Google and you get it in Amazon. You find thousands of troponin sold in our country. So you know your troponin, what assay you are doing, and what is the limit of your assay, what is the CV of your assay, and everything you must be knowing before you actually start interpreting in the right way. So the specificity of HS troponin is around 80 to 85%. The earlier generation troponins were far more specific. Serial troponin is very important to increase the specificity, even though they are very, very sensitive. The HS troponin are very sensitive, but they are limited specificity. But what is the important delta, that is the change? Suppose you are doing 2 values of HS troponin, what is the important level at which you will consider that change as important? We don't know that level, but most likely ESC guidelines say that 20% relative change is an important value. So one more thing, with the advent of corona and other things, I think CT angio, CT has become very important. With the advent of stent pricing also, the PCI yield has come down. So it's better that cardiologists learn CT angiogram, how to do and how to interpret. Why should we talk about this in NSTEMI lecture? That is because of this trial called Verdict trial, which actually has incorporated CT angiography as an algorithm to diagnose whether to use invasive coronary angiogram or as a reference standard. So patients with acute coronary syndrome, so the coronary CT angiography was negative in 26% of patients, and only 5% was non-diagnostic. In 69% of patients, it was actually positive. Out of this 69, only invasive coronary angiography is negative in 9% of patients. So it has actually, and then if it says negative, it has excellent negative predictive value. So it has excellent negative predictive value. So it's a very good rule. Possibly there could be role of screening of CT could come up as in the future guidelines for NSTEMI. Most important tool that we have is put them together. So we all, as a clinician, experienced clinician, can identify which patient is at risk. But for everybody, I think these 2 scores are very important: the TIMIRI score as well as the GRAY score. These 2 scores, one of them should be calculated or must be calculated in every patient who is admitted in your ICU. Everybody should have this score. So one is the TIMI score, where I think the out of number of risk factors actually correlate with the outcome of NSTEMI. And these are the various points that are considered. 0 to 2 is considered low, 3 to 4 is considered intermediate, and 5 to 7 is high. Actually, these scores don't need anything major, that you can actually instruct your ICU staff. The nurses can actually calculate and tell you. It's a very simple score. It just needs age in years, history of congestive heart failure, history of myocardial infarction, resting heart rate, systolic blood pressure, elevated cardiac enzyme, PCI or not, and then initial serum creatinine. What is the serum creatinine? That's all it needs. And actually, it beautifully gives you the the prognosis in that particular patient. So anything that is 1 to 108 is low, 109 to 140 is intermediate, and 141 to 1. 140 is a golden line for cardiologists. Like anything above 140, we are supposed to intervene, take them for an invasive strategy. So I think this is where the curve starts to climb up exponentially. This is where the cutoffs have been designed. So coming to the therapy of NSTEMI, so basically dual antiplatelet preferably for 1 year, and then one antiplatelet, mostly aspirin for lifelong, high intensity statins for lifelong, beta blockers preferably lifelong. There can be a debate on that after what is the role of beta blockers in this. Anticoagulation, initial treatment always with low molecular weight heparin. AC inhibitors should be preferably used in all patients. And for angina control, we can, acute stage, we can use nitrates and morphine. And there could be a role of GB2B3A in patients who are not undergoing PCI in very high risk patients. So aspirin is for lifelong. You can choose between ticagrelor, prasugrel, and clopidogrel, even though ESC guidelines recommend ticagrelor for most of the patients. And then ESC guidelines somehow prefer fondaparinux, even though in India, most of us are comfortable in using enoxaparin. So they must be used in all patients with proven NSTEMI. So the most important question is which patient should be wheeled into cath lab. So this is a very important question that actually has been addressed, and there are 4 important questions that we need to address. So should we be following, everybody should be undergoing revascularization, or we should be selectively intervening, and how early we should do that revascularization if you have decided that you want to do this thing, or and then what is the role of CABG? These are the 4 questions with which I will end the lecture. So in whom to intervene? In the distribution of coronary unstable angina, 13% are normal, 26% are SPD. Unlike in STEMI, where more patients are likely to have single vessel disease, actually 1/3 of them are triple vessel disease, 10% are left main, and 28% are DVD. So basically, the proponents of routine invasive says that many of them actually have significant heart disease, significant disease. Why don't we do it in everybody? Because it shortens hospital stay, it relieves symptoms, it decreases recurrent admission, it improves prognosis. So there are many trials that look into the routine invasive versus selective invasive. The most important ones are FRIX2, TACTIC, TIMI-18, RITA3, and ICTUS. And these are the outcome of these trials. The routine invasive decreases mortality around 25%, MI by around 18%, rehospitalization by around 31%, but actually it leads to a slight increase in early risk of MI and death. That is where the confusion has started. So very important. I think this is a very important slide actually for even the cardiologist to understand. I think the maximum difference that you can actually attain with an routine invasive strategy in NSTEMI is only in the high risk population and in selected intermediate risk population. The actual difference that you can actually produce in a low risk population is extremely small. That's a very important slide that everybody should know. I think all NSTEMI is not equal. I think clearly the highest risk benefit the maximum with selective invasive strategy. So once you decided that patient has to go for an invasive strategy, why can't we do it like a primary PCI? Like once a patient enters the emergency, just wheel them into the cath lab. So why shouldn't we do that? Because possibly the various trials actually looked at various timelines, that is 48 hours in TACTIC STEMI, 72 hours in RITA, and 8 to 10 days in FRIX2. But there are important questions. There are important pathophysiological difference between STEMI and NSTEMI. Could passivizing the plaque lesion could help, and whether antithrombotic therapy can stabilize the vulnerable plaque and allow the various.
slide gulo ki o dekhabe na ami ekhan theke dekho share screen ekta kotha bujhte parchi na.
So
share screen option dite hobe na.
There is some people may argue that jo kal karna aaj hi kar do. What are we going to achieve by waiting and watching? So this is actually addressed very nicely in the TIMAX trial, where actually the primary outcome was death, MI, and stroke were actually not different if you intervene within 24 hours and delayed invasive versus 36 hours, even though secondary outcome were different. So there are various analyses that has actually looked into this detail. These are the various trials that has actually looked into this, and actually. So most of them are actually not very, except for recurrent ischemia, where there is definite benefit in terms of doing a early invasive strategy. But rest of the major things like death, MI, and major bleeding, actually it hardly matters whether you do it within 24 hours or later than 24 hours. So why there is so much of confusion is because most of the trials have used different cutoffs. There is no single answer, and it is best decided by patient-related factors. So mostly within 72 hours, a broader time frame is there. But the goal is to prevent progression of thrombosis into complete occlusion and evolution of a STEMI. Very early, in terms of less than 2 to 3 hours, is of not additional benefit, unlike in STEMI. So what you should do? I have given enough of lectures, so what should we do? So I think if there is a very, very high risk, like within 2 hours, if there is recurrent angina, if there is shock and electrical instability, within 20 hours, the patient has dynamic changes, positive rise in troponin, and Gray score of greater than 140. If there are secondary high risk like diabetes, left LV ejection fraction 40%, if there is renal failure, and then Gray score of 1 Gray score, all this should get within 72 hours, and low risk patients should preferably go for a ischemia guided therapy. And this is what has been summarized in the latest guidelines also. And this has an important role in patients with diabetes, ejection fraction, reduced ejection fraction, left main and proximal LAD stenosis, and multivessel disease. And if patient cannot tolerate extended EAPT, and if there is a high syntax score, all these patients should actually go for a CABG rather than putting one stent at that time and then referring the patient to CABG later on after 6 months. That is not a good strategy, because the culprit vessel identification is a very tricky business in NSTEMI as compared to STEMI. I think I hope I could cover in 15 minutes an outline of NSTEMI as much as possible. Thank you, sir.
Yeah, thank you, Dr. Ramakrishnan. May I ask you a question? Where do you put this MINOCA in NSTEMI?
Sir, MINOCA is actually, even though the studies show that around 13% of patients have normal coronaries in all patients presenting with NSTEMI. But if you actually look at the diagnosis of MINOCA in this, particularly once you diagnose ischemia, then the number is actually half of what is it. Maybe around 6% of patients actually present with real ischemia with ACS and who turn out to be normal coronaries. So that will be roughly around 5%.
Do we treat them with the dual antiplatelets? MINOCA?
If you have a troponin elevation and if ECG changes are there, then possibly I think I would like to treat them if there is a ACS-like presentation.
Yeah, Dr. Devdatta, if you have anything to ask.
Yeah, thank you, Dr. Ramakrishnan. It was a hurricane of a lecture. I had concentrated very hard to follow you, but you have covered everything. My question is that for the general practitioners who are here, how would you summarize your lecture when they are faced with a patient who is like...
So I think I would like to summarize two important things which actually doesn't happen. Yeah. That is one important thing is that even though the treatment-wise everybody treats them with dual antiplatelets, give nitrates, give enoxaparin, all these are generally given in our practice. In statins, always given. So there is not a problem in medical therapy, but the problem is in knowing the troponin. So you must understand your troponin. You should know what troponin you are doing and what is the cutoffs for those troponin and what is the sensitivity and specificity of the troponin that you are using. Number one. Number two, Gray score must be calculated in all patients who are admitted. It's a very simple score. I think it must be administered to all patients admitted to NSTEMI across the country. So Gray score is a very important, very easy risk stratification marker. And I think not all patients who are admitted with, but most of the patients will need a revascularization, but many of them may not need within 24 hours. That's not an early or immediate revascularization. So risk stratification is very key in NSTEMI because it's a bundle of many diseases. Like it's not one particular thing.
Yeah, I think there is one point that I would like to highlight, that in this condition we use a lot of drugs that can predispose the patient to bleeding. And occasionally you might have the patient who can present with severe angina who is actually anemic. So during physical examination, I think it is very important to assess that whether the patient is anemic or not, because you don't want to give them heparin and dual antiplatelets on top of the patient having a low hemoglobin and possibly a bleeding source somewhere. It could be a gastrointestinal bleed from a peptic ulcer or some other reason. So this is one aspect I think that should be looked at when the initial assessment is made by the bedside.
Thank you. Thank you, Devdatta, Dr. Pandey and Dr. Ramakrishnan. Thank you very much for this wonderful